Kind of like that? Okay. Well, thank you for having me. I like to talk about pancreatitis sometimes. We see a fair amount of it around Detroit area. Everyone seems to send all of their patients down to Henry Ford for pancreatitis from everywhere around the state and the region. So I think it's an appropriate topic for us to talk about. Okay. How do I make it go? Oh, just like that. Okay, so no disclosures, of course. So what are we not going to talk about today? We're not going to talk about anything about chronic pancreatitis. It's all going to be about acute pancreatitis. Chronic pancreatitis is a not completely, but it's a separate entity, different surgical treatments and chronic stuff with that. And quite frankly, not as much fun as acute pancreatitis. So we're not going to get into chronic stuff at all. So we're going to talk a little bit about resuscitation. We'll touch on antibiotics, talk some about nutrition, talk about how long we're waiting, because it seems like we're always waiting for them to either get better or get worse or do something about the pancreatitis. Complications that the patients suffer from with their prolonged pancreatic patients, and then getting some surgery and procedures. Quite frankly, not a whole lot has changed in the past several years for acute pancreatitis. The majority of what has changed is more of our surgical approaches of how we're going to attack pancreatitis or walled-off pancreatic necrosis, where endoscopy falls into there. Endoscopy has taken a much larger piece of that than surgery has. So things are shifting in that aspect. But beyond that, not a whole lot has changed overall in the past couple of years, but we're going to touch on some of this. So evolution of pancreatitis, at least when I started, everyone got antibiotics. Everyone's given antibiotics for 2 weeks, and then they said no antibiotics for anyone. And then a few years later, they said antibiotics for everybody. Then they took away those recommendations and said no antibiotics for anybody. So the antibiotics has kind of vacillated back and forth for several decades. We used to do MPO until the pain's gone, sit them in the hospital, wait till the pain's absolutely resolved, and then let them start eating. That's kind of gone. Lots of IV fluids, maybe a little more judicious about. We still give a fair amount though. And then, a bunch of these patients went right off to open surgery, within the first 24 hours if they had necrotic pancreas, where we just don't do that at all. And I can't remember last time that we have done that. No one's recommending that we do that, but we'll get into the open or the part of surgery where that comes into play for some of our pancreatic patients. So, there's a lot of pancreatitis going around, greater than 275,000 a year, 2.6 billion. Mortality rate can be 5%. Now we'll see some different mortality rates because it depends on what your severity level of your pancreatitis actually is. And that'll kind of dictate where your mortality rate usually falls at. But in general, it's about 5%. So our causes, as we know, gallstones and ETOH are big ones that we're always asking everyone about. And majority of the time, we'll find that either it's a gallstone that's passed and our LFTs are bumped, or their ultrasound or some study shows a stone in the bile duct, and the bile ducts are dilated. About 40% of the time. Alcohol is about 30% of the time. And we usually be able to get a good history out of the majority of patients that they're heavy drinkers and they're in withdrawal, and now they've got the pancreatitis. So those two are fairly easy to kind of get an idea of what's going on with those patients. Then it gets a little bit more deeper in the weeds when we can't figure out they're not gallstones, they didn't pass the stone, it's not alcohol, maybe it's the hypertriglyceridemia. So you check a triglyceride level. There's always drugs. We put a few drugs down here. A few always show up on board exams anywhere, but you look at the list of drugs of most patients and you can figure out a majority of them probably cause pancreatitis in somebody during some research study. So therefore they all cause pancreatitis. So which one is it and how do you determine that, right? Tell them to not take all their drugs anymore, just stop everything and see if it comes back or not. It's not a good method. So it's hard to tell if actually drugs are causing the pancreatitis. And of course, there's some mutations in genes and some genetic pieces that go into that. Autoimmune, less than 1%, maybe IgG or IgG4 levels may be increased. Trauma is a small percentage. We always ask about it. It actually is uncommon to have a traumatic cause of pancreatitis. Usually those will be the kids who fall on their bicycle handlebars directly, or anyone who has a direct blow to the mid-abdomen, a significant amount of direct force to the mid-abdomen. That may give them pancreatitis. More commonly, they actually crack their pancreas, so it's not really a pancreatitis that they get. So that's fairly uncommon. Some infections, they always quote viral infections can cause it. And then surgical complications, up to 5 to 10% of the cabbage patients, even though we don't do a whole lot of cabbages anymore, they can actually get some form of pancreatitis that goes along with it. And we're dealing with some of the sequelae of that. Usually it's more of a mild form of the pancreatitis and goes away pretty quickly. So several causes that we know that we can get through. And then what I didn't put in here is the 30% of the time that we have no idea what the cause of the pancreatitis is, and we're just guessing things. So how are we diagnosing it? Still the same rules are applied. At least two of the following: abdominal pain, amylase or lipase greater than 3 times upper limit, lipase a little more specific, and or radiographic evidence. I was just showing this picture here. This young lady came in the other night. Her amylase and lipase are perfectly normal, but the distal part of her pancreas here is inflamed. There's actually probably a little bit of necrosis here already, which is kind of unusual. It was early on, only started 24 hours prior, supposedly. Wasn't a drinker, didn't pass any gallstones. We're trying to figure out why she got the pancreatitis. But she had radiographic evidence. She had abdominal pain in the appropriate spot. Therefore, we called her pancreatitis and we're treating her as such. So that's what you need for your diagnosis, not a whole lot. A lot of this stuff comes from American College of Gastroenterology workup. There's International Pancreatology Association. There's another couple associations for pancreatitis that you can look up. All their guidelines kind of mesh together. They recommend ultrasound in all patients with pancreatitis, especially looking at the gallbladder and gallstones. If no stones or alcohol, then triglyceride levels should be checked, and you're looking for high levels. Greater than 40 years old, I guess you're getting a CAT scan looking for tumors. That is uncommon, though, to find a tumor that's causing your pancreatitis. But I guess it can happen. Endoscopic investigation with idiopathic pancreatitis should be limited, since limited value. We're going to get into that a little bit later, where we're throwing ERCPs and EUSs in here. And then idiopathic should be referred to another center so they can figure out what's going on. So we can often find a cause, but like I said, maybe upwards of 30% we don't actually know. Genetic testing if they're less than 30 years old and no cause is evident. So we'll start off briefly with a little bit of grading. There's a few different grading systems, and are we grading for radiographic? Are we grading for so we can talk amongst ourselves? Are we grading for severity? Are we grading for mortality? What are we doing? There's a double AST grade. This kind of gives us an idea of what we're doing, especially talking amongst ourselves, reading CAT scans. It's American Association for Surgery of Trauma. And because now we're not just trauma, we're acute care surgery. So, all that stuff gets lumped into the trauma guidelines now. So the AAST put out these several years ago, anywhere from, you grade 1 acute edematous pancreatitis up to your grade 5, your extra pancreatic extension of pancreatic necrosis involving adjacent organs. So, a whole mess of bad pancreatitis going on. Grades 1 through 5, you can imagine as the grades go up, it gets worse pancreatitis is what it comes down to. What's it telling us? It's telling us that you have increased length of stay and readmission rates and some other things that are going on, increased mortality and morbidity that goes along with it, is what the AAST grading has been shown. Just a couple patients. So you can start here at interstitial edematous pancreatitis. You got a little inflammation around your pancreas. Your pancreas looks pretty with the lightening up with the IV contrast. And you start to get into then necrosis, where you get this patchy area plus some fluid around there. And we'll get into the different variations of the pancreatitis and the progression of them. But that's a AAST grading, gives us some information, gives us an idea of maybe how sick that they might be. Also, some prediction models say age over 60, severe coexisting conditions, BMI over 30, long-term heavy alcohol use, kind of things you would think that if you have these comorbidities, you are probably going to do worse when you have pancreatitis with it. So nothing that is just outstanding there. Ranson's criteria, Ranson's always shows up on some board exam someplace. How often do we pull out Ranson's? Quite frankly, I don't even know if the residents know Ranson's anymore. They should. I should be asking it more. We use some different grading systems, like I said, besides Ranson's that we ask. But here's your Ranson's criteria. And really, what's it telling you? It's really giving you an idea of mortality. And of course, as you have more of the criteria there, your mortality is going to go up. And you can see as you get to 7 to 8 of the criteria, you actually get up to mortality of 100%. And that just makes sense with what's going on, ages and liver function that goes along with it. You're not oxygenating well, your calcium's driving way down because of your pancreatitis, all things that kind of make sense. So worse Ranson, higher mortality. Multiple scores predicting severity, unable to predict those with acute pancreatitis who will advance to severe pancreatitis. That's a problem that we have, though. It's hard to say, you're going to be fine and go home tomorrow, but this person over here is going to get worse and live up in the ICU for the next 6 months. It's hard to say who that's going to be. We did our own study here before, and we couldn't tell what would give us the severity of level, what is actually going to mean a patient's going to get sicker, and also what does it mean which patient's going to get infected or not. That's what we really can't tell, and that's where infection really changes the game plan with a lot of the patients. And it's not just your standard pancreatitis treatment. You start to get into infection of the pancreas, and you're going down a whole separate pathway. How can we tell who's going to get infected? We can't, and that's what the problem is. I would love to figure that out. We've got enough pancreatitis around here. Maybe we should be able to. So some of the Atlanta classification or definitions are the revised Atlanta classifications and definitions that came around in 2012 and 2013. Different phases of acute pancreatitis. You got your early, about a week, result from host response to pancreatic injuries. The pancreas is not happy, gets a little inflamed. And you got your moving to your late phases, which is after about a week. You've got your persistence or your systemic signs of inflammation by local complications. So that's where things really take off. You hope that your patients stay in the early phase of acute pancreatitis, they get over pretty quickly. We try to keep them out of getting to the late phase, but sometimes we can't do that. And often occurs along the spectrum. So either they get the mild pancreatitis and then it stops there and we can resolve the issue, or it's a continuum of mild to moderate to severe with complications. So it often goes along that track. And you hopefully can cut it off somewhere early on, because the mild is about 80% of patients. Interstitial changes, not systemic problems going on. Then you got your moderately severe patients, transient local or systemic complications for maybe about 48 hours. Then you get in your severe. That's really, you start getting your organ failures. That's where you don't want to get your patients into, is to the organ failures. And sometimes it's hard to prevent that from happening. But it's a continuum along the spectrum that usually happens. Here's your revised Atlanta criteria. Once again, your mild, moderate, and severe. And really, all this is telling you is you're developing organ failure as you're going along, and the organ failure is not going away quickly, right? So organ failure that lasts is going to be into your severe. And that kind of tells us maybe the direction they're going to go and what else we have to do for them in the meantime. Then there's, of course, a bunch of local complications. We're going to talk about all these in just a minute. And then organ failure, there's different criteria for organ failure that the Atlanta classification is given. Severity, once again, the mild patients about 80% of the time, and the mortality rate should be low. That's where you get those lower rates of 1 to 3. So hopefully your patients aren't dying from the mild pancreatitis, but the moderately severe, the mortality can get up to 35% or higher on those patients. So it goes up significantly. And thankfully, it's a lot less of the time that we see the moderate to severe. It seems like here at Henry Ford, everyone seems to be in the moderate or severe. And I think that's based on who we're getting sent to us. Because often with the transfers we get, usually it's the patient's got pancreatic necrosis, we're sending them to see you. And that's usually where everyone kind of changes their pathway and sends them to the tertiary care center. It seems much more prevalent lately also. So if you're looking at the Atlanta classifications, you're breaking things down into interstitial edematous, which is usually your early, and then your necrotizing patients. And those kind of go in two different pathways of what we're doing. Interstitial edematous, majority of patients, once again, homogeneous enhancement of the pancreas, usually resolve in a week. You see on the picture here, you got a nice, pretty pancreas. It's all lighting up because you're giving IV contrast, because that's what helps you see the pancreas. Everything's lighting up, a little bit of inflammation. Hopefully that goes away. Once again, it can progress to the moderate, to the moderately severe, and then to the severe. But hopefully this interstitial part doesn't get infected. You don't get the necrosis, and this resolves early on. Necrotizing. Less percentage of patients, like I said, it seems to be everyone here is necrotizing, but it's only about 5 to 10% of patients. Necrosis evolves over the days because, once again, it's a progression, right? You get your pancreatitis, you get your inflammation, and then from there you start getting death of part of your pancreas. Early CTs underestimate. So just remember, you get your first CT scan, and that's not going to tell you the whole story, because that's going to progress. The parts of your pancreas dying off will get worse, okay? So the first CAT scan really doesn't tell you the whole story. And it's usually not mild necrotizing. Now, I showed you the first CAT scan, the girl who had some pain. She had a little bit of necrosis, a little bit of inflammation. She's gone home. So she's one of the people that are on the outlier. She had some necrosis that really didn't progress, and she got better, and she got the necrosis early, supposedly per her time frame that she gave to us, and she got better. But that's not a majority of patients. Usually the necrotizing patients, they'll stay around a lot longer, and it's usually not just a mild case. And you can see some patients here. Really, the CAT scans are very important because they show you part of the pancreas lighting up, part of it is not, part of it are little patchy areas in between here that are not lighting up, and that's your pancreatic necrosis. And once again, that may be an early CAT scan, That doesn't give you the whole picture or what their actual clinical course is going to be. So you can have several local complications or local continuum of what goes on with the pancreas: peripancreatic fluid collection, pseudocysts, acute necrotic collections, walled off necrosis. Those are the big things that happens with the pancreas. We'll get into those in a second. And of course, you can get gastric outlet obstructions, colonic necrosis, splenic portal vein thrombosis, enteric fistulas, all those type of things. And we'll get into those in a little bit also. So suspecting local complications, we have persistence or recurrence of abdominal pain. So those patients that you bring them in for pancreatitis, you're treating them, and they're either just not getting better or they're getting worse specifically. I always advocate to repeat in their CAT scan because usually something else is going on. Something has progressed, or they've developed a complication, or they have necrosis that's increased, or now they've got infection, or they've got a fistula, or something has happened usually when it's just not going away, or they have a recurrence of their pain, or they get significantly worse. You can also see it when you have increase in serum pancreatic enzymes a second time. We generally don't look for that a whole lot and keep rechecking enzymes. It's more on a clinical basis and a radiographic basis of what's going on. Increasing organ dysfunction, like I said, the patient's just getting sicker or they're getting septic. There's probably something else going on or a progression of the disease. Effective pancreatic necrosis, the big thing that we all worry about, we would love to prevent and have no one get infected pancreatic necrosis, but there's no correlation between the amount of necrosis and infection. So, a ton of, the whole pancreas is gone and it looks like it's all full of air and stuff. It has no correlation with how sick they're actually getting. You can have a little bit and get very sick, you have a lot and not be that sick. We'll get into this a little bit more of treatment, but generally it's going to be antibiotics, probably something else. Once upon a time, it used to be immediately off to the operating room. As soon as you get that CAT scan, a bunch of air in there. That's not the case anymore. We're going to see what to do with that. And then, just for terminology, pancreatic abscess, that's actually gone away. We're not using pancreatic abscess anymore. Doesn't really describe what's going on. And we'll see how that comes into play here. So pancreatic pseudocyst usually is encapsulated, usually greater than 4 weeks. So it's some of your longer term sequelae. Usually it's well defined. You can see in the picture here, this is nice, pretty pseudocyst here, which has a pretty good wall around it. And that we can take care of a certain way or not take care of it at all. Some of these, or majority of these, actually, we just leave them alone unless they're having symptomatology of these. But there's some other ways we can deal with them now besides a surgical way to deal with them. But these, a majority of them will go away on their own. You got your acute necrotic collection. That's when you got pancreatic necrosis. You can see this pancreas here. Some of it's lighting up. The rest of it is who knows where. You've got a bunch of fluid that's around here. So it's acute necrotic collection. It's earlier on with necrosis, and it's a fluid collection. So it's fluid plus necrosis. There's not a great wall on here, and it's heterogeneous, kind of mixed. Why is it kind of mixed? Because there's dead pancreas and live pancreas all kind of floating in there. Wish I could show you guys a picture of what it actually looks like in the operating room because it's nasty. And it's just like a wet sock that someone is soaked in pus and poop sitting in the middle of the patient's belly is what it looks like, quite frankly. There's the walled off necrosis, or WON, or wampum. That's my favorite. It's a wampum, walled off pancreatic necrosis. It's a mature encapsulated collection. It has necrosis in it, well-defined wall, greater than 4 weeks. This is what we like to see, because this is a little bit easier to deal with. We have some other methods we can deal with it versus the acute necrotic collection. But when you get to the walled off pancreatic necrosis, this is a longer term thing. And when we talk about the wall, we're talking about the definition of what's going around this collection. So you can see this one here has a rim that's coming around it. This one in the upper left here has a rim that's developing around it. And compare that back here with your acute necrotic collection. It's kind of all fuzzy here. Where is the edges at? Where are they not? Those come into play in how we deal with the patient, especially when we're talking about endoscopic treatment of these patients. And so when you start talking with the GI folks about what we're doing with this, they like to see a nice wall, because the wall is what you need to take care of it endoscopically. It makes things much easier, and we'll see why in a couple of minutes. Now, you may say, well, how do you know it has a nice wall to do anything with it, right? How do you know when that time is? I don't know, a little bit of it's a guess, a little bit of it's on the moon phase outside, if it's going to be appropriate or not, or the day of the week, or the staff you're talking to, but it is very subjective. You can say there's a nice wall here, but there's nothing that says that is a great wall, because you have to be able to instrument through that or sew to it or do something with it. We'll get into that in just a minute. But that's why we're always looking at this wall. And that kind of also tells us how far along in the process we are. If there is not a great wall, such as this acute necrotic collection here, this is earlier on. This is later on. This means that a majority of that pancreas that's going to die has died. So the process is hopefully slowing down and you're not attacking this pancreas too early. You go into someone's pancreas or try to do something with this early on, it's not done. It's not done dissolving the rest of the pancreas. The pancreas hasn't finished dying off yet. So you have to give it some time. But when you see these walls around here, then you start thinking, hopefully things are starting to coalesce. Hopefully inflammatory response is starting to go down and you can do more surgical or endoscopic interventions with these, or interventional radiology interventions. So this is just a different table showing a similar thing here. You've got your acute peripancreatic collections or fluid, which is early on. Interstitial pancreatitis, usually homogeneous fluid, no fully definable wall next to the pancreas. And you've got your acute necrotic collection. What's that? That's the same fluid collection, but now there's necrosis of your pancreas, and that's early on. Heterogeneous, no definable wall. Later on, you then get fluid collections that turn into pseudocysts with usually interstitial pancreatitis, well-defined wall next to the pancreas, or you get walled-off necrosis from your acute necrotic collection, right? So your acute necrotic collection has taken enough time, and now the wall's formed around it. So these top ones are early on what goes on, and these bottom ones are later on, and the ones on the left are things that are just usually interstitial pancreatitis and plain old fluid, and on the right has some component necrotic tissue in there. So those are really where you kind of separate off what's going on with the patient. You kind of figure out pathways that you're going to go with them. Usually these acute peripancreatic collections, you're going to do nothing with it. Acute necrotic collections, most often nothing early on. Walled off necrosis, sometimes we need to do something with that. And pseudocyst, more often than not, we don't need to do anything with that. So it kind of gives us an idea of where we're going here. Another way to find this, besides the revised Atlanta classification, is determinate-based classification of acute pancreatitis. And it's telling you the same thing. You've got a mild acute pancreatitis, no necrosis, and no organ failure. Okay, that makes sense. You get all the way up to your critical acute pancreatitis, and that's the infected ones, and they have persistent organ failure. It just kind of makes sense. And as you go through here, you've got more necrosis that's developing. So it's a similar classification of what's going on, just kind of give you an idea where you are in the spectrum of the acute pancreatitis. So how are we going to manage our patients? It's still fluids. We're giving fluids still. Hypovolema usually is already occurring from vomiting, reduced oral intake, third spacing fluids already, and you third space a huge amount of fluid with these pancreatic patients, especially in the retroperitoneum. Several factors also lead to decreased blood flow in pancreas, eventual necrosis, release of more pancreatic enzymes. You're trying to slow that down, so you're giving fluids early on. Some of the recommendations out there, 5 to 10 milliliters per kilogram per hour, 200 to 500 milliliters per hour. We have all of our monitoring devices now, right? We got our Vigileos and our echocardiograms and our point of care ultrasound and everything else that we can use now to give an idea of a patient who's responding or not responding. So we have a little more goal-directed care that we can do, but it's probably going to be a large volume of fluid that we need to get into the patients. Normal saline versus lactated ringers, no real consensus over there. Some limited data say maybe lactated ringers a little bit better. It used to say no Hespan or head starch in these patients. There's something more recent that came up to say maybe we can give that. There's no clear evidence for that. So it's really just your crystalloid that you're giving in the first 24 to 48 hours and being fairly aggressive with the fluid management. Nutrition, so that's fluid, so they need fluid. Nutrition, remember, like I said, the evolution was we made everyone NPO for days on end, right? That's not the case anymore. We really want to get to nutrition of people. Nutrition has been shown to decrease your rates of infecting your necrosis or infecting your fluid collection. So we want to get nutrition as soon as possible. I think it's like a majority of our patients now, whether they have pancreatitis or not. So the mild acute ones, you can feed them right away. If they get significant increase in pain or something changes, you can probably stop it, but you can feed them usually right away as they come on in. And feeding them liquids or real food doesn't matter. Limiting factors, of course, if they're throwing up, severe pain, if they have a nausea, or if they have an ileus associated with it. Most of them won't have an ileus with the mild acute pancreatitis, but they may develop one. If you can't do that, nasojejunal, nasogastric, same thing, put it in the stomach, put it in the jejunum. Same in the trials and the meta-analysis, oral diet within 72 hours and consider a tube. So you try them for a couple of days, and if they just can't get the nutrition in, then maybe put a tube for them. It really doesn't matter. The whole theory of you're activating the pancreas by putting it into the stomach is gone. That's out. The real problem with giving patients food in the stomach is usually the ileus that is often associated with the pancreatitis, or a gastric ileus, more importantly. The stomach just isn't working. It's inflamed. It's angry from sitting right on top of that angry pancreas. It just doesn't want to work. So they throw up and they can't tolerate their feedings. It doesn't mean that you can't put food into their stomach or bypass it with a nasojejunal tube. So one way or another, enteral feeding is very important for these patients. Feed early in mild acute pancreatitis and severe. You feed to prevent infection. That's important. And TPN, if they just can't get the diet in, you can't get the tube in, they don't tolerate it still despite going past the pylorus, and I guess give them TPN. But it won't help you with your infection rate. So you really need that enteral nutrition, which helps the most. Once again, nasojejunal or gastric, they're going to be the same. Bowel rest leads to mucosal atrophy, bacterial translocation. That's where you get your infection-free fluid collections, which is your dreaded complication. You don't want that. So early feeding decreases length of stay, infections, mortality, et cetera, et cetera. Early feeding is good. Antibiotics, well, in 2021, we're still not giving prophylactic antibiotics. 10 years ago, we were. 15 years ago, we weren't. 20 years ago, we were. So we're back to not. So as of right now, there's still not a recommendation to give prophylactic antibiotics. Because the question always came up, will you give them for how long? And you give them when? And when do you stop them? And where in there, what else makes the factors for giving the antibiotics? There's no real method to it. It was just give them for a couple of weeks and hopefully this will help. So antibiotics prophylactically generally don't do. And then of course unless you're giving it for some other reason, they've got pneumonia or something else. So antibiotics for infections are extra pancreatic, no prophylactic antibiotics. Suspect infected necrosis in patients with pancreatic or extra pancreatic necrosis who deteriorate. We'll get into when to do those antibiotics. If you just can't figure out what's going on, they're just getting worse, bad pancreatitis, maybe we should give some antibiotics, but there's no clear evidence for that. Routine use of antifungals not recommended at this time. Antibiotics need to penetrate the pancreatic necrosis, of course. And how do you penetrate pancreatic necrosis? Let's be honest, you don't. You don't penetrate dead tissue. There's no blood flow to dead tissue. Therefore, no antibiotics go to dead tissue. ERCPs and pancreatitis, a lot of times they used to recommend that everyone gets an ERCP looking for that retained stone. So just doing the ERCP anymore, we probably should not be doing. The GI guys won't do it either because you have a potential for introducing infection into the pancreatic parenchyma. So we try to avoid the ERCP. When are you going to do it? They got the cholangitis, okay? Somebody's blocking those bile ducts. That's an easy one. You get elevated LFTs, dilated bile duct, jaundice. If you're really thinking cholangitis, you need to decompress them. ERCP is going to way to go. Decompression surgically nowadays is very, very, very infrequently done, unless you can't get it done via ERCP or PTC. So the easier on the patient's body is going to be one of those methods over a surgical decompression. But we also have now, remember, we have MRCPs, at least at tertiary care centers, fairly readable. So fairly easy to get. So you can get one of those if you're suspecting that there might be a stone, maybe not. Let's get an MRCP so we don't introduce bacteria in the biliary system needlessly. Or a lot of GI centers do endoscopic ultrasounds now. So they can go in there without introducing anything or wires into the biliary system, but they can get the ultrasound out, take a look at the bile ducts, say there's a stone or no stone, and then they can either proceed with a actual ERCP and stenting and drainage, or they can abandon the procedure, say there's nothing in the duct anyway, so nothing for us to do. So there's some methods to keep those ERCPs down to a minimum to decrease the chances of infecting the pancreatic tissue. Cholecystectomy, when are we going to do those? Of course, we're doing those with our patients that have gallstones that we think cause a pancreatitis. Generally, we try to do that before they leave the hospital. They have about 30% relapse rate if we don't do them before they leave. Their pancreatitis will come back about 30% of the time in the next 6 weeks. It's not 100% absolute. It doesn't have to be done, but I would recommend anyone that we think has gallstone pancreatitis, a mild case of it, you get your gallbladder out before you leave. If you don't want to, you can't, you got to go home and feed the dog, then we schedule you for very soon after outpatient and get the gallbladder out. Those are usually for the mild pancreatitis. When you start getting to moderate and severe, it's a different story because you have a lot of inflammation around the biliary system that you really don't want to get into. When you're doing the gallbladder, you don't want to infect that fluid either. You would like to see all that resolve. You want to see the inflammatory response hopefully resolving for the patient instead of putting them through the undue stress of having a surgery. So there's no emergency to cholecystectomy. You just have to remember that. But the mild cases, we try to get rid of it before they leave. Necrotizing pancreatitis should wait for active inflammation to resolve and fluid collections, just like I said, before you take out that gallbladder. Let everything calm down. And usually that's an outpatient procedure several weeks down the road. Okay, so we've got peripancreatic fluid collections and we've got walled-off pancreatic necrosis, or we've got pseudocysts. So you have these things. Okay, so now what do we do? A little bit's dependent on where we are in the spectrum of their disease process. A little depends on if they're infected or not infected, but what do we do with these? So here, asymptomatic pseudocyst, pancreatic, and or extrapancreatic necrosis need no intervention regardless of the size, location, or extension. The question always comes, what's asymptomatic, right? So you see this one here. Is this a pseudocyst? This is probably walled-off pancreatic necrosis. So there's really no pancreas left in there, maybe a little sniblet over here. There's no pancreas in there, a little bit of heterogeneity in there, probably because there's some dead pancreatic tissue. What do you have to do about this? You don't have to do anything about this, okay? It all depends on what they're doing in their clinical situation, if you think it's infected or not. Based on the CAT scan, it doesn't really look like it's infected. And if it's causing symptoms, and what are symptoms? Some of them are easy to tell. Early satiety, I can't eat, nothing's going in. Gastric outlet obstruction, nothing's going through. Those are fairly easy ones to say you're symptomatic from it. Continued pain. A lot of pancreatitis has pain. A lot of them develop some chronic pain with it. So is your pain secondary to your pseudocyst or your walled-off pancreatic necrosis? Is it not? Were you getting better, then everything stopped getting better? It's hard to tell some of those symptomatic patients or asymptomatic or where they are in their disease progress and if doing or taking care of this cystic structure is going to actually help them. You're looking for the bigger symptoms, like I said, gastric outlet, early satiety. You know, do I think the cyst is pushing on something? Does it look like they've got a splenic vein thrombosis already from the pancreatic inflammation? And I don't want that to progress to a portal vein thrombosis. Do I want to go drain this fluid somehow? All those things come into play. Once again, it's a multidisciplinary decision because there's no absolute recommendation on what to do for some of those patients. So if I take a look at this guy here, who's got probably walled-off pancreatic necrosis, closer to the end of his disease process going on, and this is just sitting there on CAT scan, I may say, well, just leave it alone. But if he comes in the office and says, or he's still in the hospital, I can't eat, nothing's going through the stomach, we're thinking about feeding tubes and such. Well, maybe we need to do something about this now, either surgically or endoscopically. Or let's say it's just a pure pseudocyst. I may wait longer. If they're not having any symptoms, I feel great, I'm going home today, I can eat. Okay, then we'll repeat your CAT scan down the road and see what things look like. You're not having any symptoms. Those are kind of the easy patients, but it's that in between, maybe some symptoms, maybe just not progressing. What do we do with those? So the acute pancreatic fluid collections, remember, these are usually early on. There's no defined wall. Most of them are sterile. Your pancreas looks okay here, but you got a bunch of fluid around it. If it goes on beyond 4 weeks, usually develops in that nice pseudocyst with a nice wall on it. Once again, if they're asymptomatic, no intervention, especially early on, because these are early cases of acute pancreatic fluid collection. It's early on, usually with interstitial edematous. There's nothing to do about those. You just let the process go on. Most of the time they'll resolve. Try to keep them from getting infected. And how do we do that? Give them their nutrition, get them on a diet, treat their pain, give them their fluids, and hopefully these will all resolve on their own. So I wouldn't do anything with this. Pancreatic pseudocyst, usually well-defined wall, usually all fluid from the peripancreatic fluid that was there before early on. Now it's coalesced. It has a nice wall around it. Usually no necrosis with it. It can be from a pancreatic duct disruption or a branch of a duct disruption. So we have to take that into consideration, what we're doing with that to treat it. And usually it's greater than 4 weeks. So that's kind of a continuum of this non-necrotic state. What do we do with these? Once again, they're asymptomatic. A majority of these will go away. The old surgery books used to say at 6 weeks, if they're greater than 6 centimeters, you've got to treat them. If they're less than 6 centimeters, you wait. There's no definition for that anymore. If they're asymptomatic, you can leave them alone, follow up on them. But you do have to be concerned, is this actually a pancreatic duct disruption and this is not going to go away, it's going to get bigger and cause some symptoms, or is it not? Because that kind of defines how we treat these patients. If this is a pancreatic duct disruption, it's causing the pseudocyst, you stick a drain in there, guess what? You're going to have a pancreatic fistula out your side for the next couple of years. That's going to continue to drain. So you kind of have to take that into consideration of what's going on. But a majority of these pancreatic pseudocysts, they don't have symptoms. You can just leave them alone and they'll go away on their own. Symptoms, you may need to do something with them. Symptoms being compression on different organs. It's hard to tell, is this compressing the colon too much? That's going to cause necrosis. There's no good way to say that. You can maybe guess on a CAT scan. It's hard to guess. Gastric outlet, that's pretty easy. I keep eating and I'm barfing because I have this giant pseudocyst pushing on my stomach. Okay, you should probably do something about that. You do need a mature cyst wall. That's often after 4 to 6 weeks. The thickness of it based on CAT scan, I don't know, personal opinion on if you think it's thick enough. Then how do we treat these pancreatic pseudocysts? Open surgery, very uncommon anymore. It's a very easy procedure. It's kind of neat to do. The residents like to do it, but we very rarely do the open cyst gastrostomies anymore. Laparoscopic or robotic, we're moving into this realm. We do a lot more stuff robotically now anyway, so that may help us. Or endoscopically really is the basis of pancreatic pseudocysts nowadays. Surgical treatment of these has gone way down. It requires several incisions or a incision, and whereas endoscopic really doesn't. And what do? They go in the stomach, they get their endoscopic ultrasound out, they find the fluid, they poke a hole in it, cut a hole with their bovie, let everything drain into the stomach. If it is a disrupted pancreatic duct, guess what? They've treated it also, because now it's just going to drain in the stomach and go down through the duodenum. So you've killed 2 birds with 1 stone. So you don't have to worry about those pancreatic fistulas and such. But you need the mature cyst wall. You need something that opposes the back wall of the stomach that's thick enough that can hold together when you open up the stomach. If you don't have the mature wall, if you don't have a wall at all, you're just going to be cutting a hole in the stomach, and the stomach's just going to be leaking out into the pancreatic bed. And that's what you don't want. That's why the wall is very important. Like I said, there's no definition of wall thickness. There's no good way to say this is a good thick wall besides time, generally 6 weeks or later, and your personal opinion of how many CAT scans you've read and how many patients you've operated on with a not thick wall. Acute necrotic collections. Remember, this is on the other side of the spectrum here. These are the patients who have pancreatitis, and they've got some necrosis, and they've got acute necrotic collection that's early on. It's fluid and necrotic tissue all kind of floating around there. What do you do with these usually? Once again, usually nothing, because it's early on. They started off the disease process. Once again, we're trying to stay away from the pancreas early on. Treat with fluids and nutrition and see what it's going to do. Is it going to work into walled off pancreatic necrosis? Hopefully it doesn't get to an infected state, or is it just going to resolve on its own with treatment? So that's usually a wait and see. Your walled off necrosis or your wampum, I love that, wampum, is when you get to your necrosis, and this is usually greater than 4 weeks. Usually you have a defined wall here, and it's a bunch of dead tissue of the pancreas that's sitting in this collection. What do we do with those patients? Once again, a lot of that depends on symptomatology, where they are in the disease process. Are they at home when you're seeing this on CAT scan? Are they still in the hospital? I often treat these as it has a nice wall. Okay, great. We can now do something about this if we need to. Question is, do we need to do anything about it? So then we start asking questions about symptoms, or if these are the patients that are sitting in the intensive care unit, they're kind of just smoldering along, right? They've been sitting there for weeks and weeks and weeks. They've gotten to this point. Now they have this nice wall around here. They've got this necrotic collection. And you're saying, well, it should go away on its own. It may not. And maybe they're just not getting over the hump. They're just not getting better enough because they've got that big glob of dead tissue that the body's trying to make go away, but it can't. They can't get over that hump. These are the ones that we may do something interventionally earlier on once they have their wall while they're in the hospital. These may be a great patient. Well, this one right here is great for endoscopic treatment. They open right up into the stomach, drain that fluid. Because you have to remember, the body's trying to fight all that dead tissue, right? You would think, well, just go take out the dead tissue. It's not as easy as that. And often they will get over that dead tissue, but it does take a while. And if the patient's just not getting over the hump and they've got a nice wall, this may be the time and the person to go in and do an intervention. And we'll see what those interventions are in just a minute. Sterile necrosis, operator, leave it. Usually you leave it. There's nothing else to do about it. Once again, unless you get to that point that it's walled off and they're just not getting past the next phase of their treatment, they're not getting any better, they're not getting any worse, those you may need to do something about, or if they have the complications from it. If it's infected, this is the dreaded thing you don't want to have. And this is where a little bit of the time we're always wondering, is it infected? Is it not infected? Except for this CAT scan here, this is what we're kind of looking for. sometimes you hope that you see this because then you really know that it's infected, a bunch of air that's in the pancreatic bed around the necrosis. So it's usually suspected by the clinical course. These patients, they have their necrosis, and all of a sudden they're getting worse, or they're getting sicker, or they're getting more pain, or the symptomatology is changing. Usually you will see gas within the tissues on the CAT scan. I say you can consider FNA. Really, FNA has really fallen out of favor. Even with sterile necrosis and guessing if there's infection in it, really FNA has fallen out. There's a significant risk of infecting the actual non-infected tissue. So FNA is really out. It's still in the books. It's still there as in a lot of algorithms, but it's really fallen out of favor for a majority of centers that you talk about taking care of these necrosis. And is it acute necrotic collection that's infected, or is it walled off pancreatic necrosis? Because once again, one of them has a nice wall, very often more amenable to an endoscopic treatment, and one of them is acute necrotic collection, which there's really no endoscopic treatment for that. And what are we going to do with that? Once again, hopefully our fluids and our and time and nutrition help prevent us from getting infected. But if we get to there, now what are we going to do? It's much more uncommon that your pseudocyst actually gets infected. That usually does not happen. It usually comes from a non-necrotic state. There's no necrotic tissue. It's a fluid collection of the pancreatic fluid only. So CT scan showing air within the collection, increased pain, fever, white count, symptoms are changing. It used to be emergent surgery. Anyone that we saw with an infected collection or infected walled off necrosis or infected acute necrotic collection, they went right off the operating room. We did a midline incision, or we did a transverse incision like they're getting a transplant, and we went down there and cleaned all that out. That's probably not the best thing to do anymore. We don't need to do those emergent surgeries. There's different things we can do to hold the patient over until either that becomes more mature or they're a little more stable, or it's an appropriate time. Because remember, like I said, again, you've got to hopefully be in, if you're going to go to the operating room or deal with these endoscopically, you want the necrosis to be done with, right? You don't want them to continue to make necrosis, and you've got to go back day after day after day as they continue to eat away at their pancreas. So hopefully you get to a point that they are now good. The pancreas is good and dead. It's not going to be any more dead. Now you can do something about it. So what do we do besides emergent surgery? Now, let's see what we do. Well, we often start antibiotics. Once again, how much is the antibiotics really getting into dead tissue? It's not. You're doing it more for the systemic effects of the antibiotics, okay? Aspiration and culture are not required. You see air there. You don't have to do an FNA. You don't have to culture it. You're culturing to try to tailor your antibiotics, but you don't have to do it to start the treatment of the patient. And once again, you're trying to wait that 4 weeks or so till it gets nice and walled off, that you can do something a little easier for it. And the whole process has slowed down, and you know that your pancreas, what's dead is dead and what isn't is not. So stable patients allow 4 weeks to liquefy and wall off. Symptomatic, minimally invasive is preferred, and we'll go through minimally invasive approaches here in a second. Antibiotics, possibly drains that we're putting in patients, and sometimes, occasionally surgery, but more often endoscopic and or just waiting. Just some EAST guidelines. EAST is the Eastern Association for Surgery and Trauma. They put out guidelines several years ago for surgery for pancreatic necrosis, and they did it based on a few studies that are out there, delaying, there's some data that was saying, or some suggestion of going early to the operating room, and within 12 days, you're going to increase your morbidity. When you go past 30 days, you actually decrease your mortality. But that goes what I've been saying the whole time. You wait as long as possible to go do your operation. The process is not finished yet, so doing it early on is not going to be of a benefit and actually increases mortality. So that's just some of the data for that. It says the same thing. Minimally invasive is probably the way that we want to be going for a majority of procedures. So once again, if we're going to operate on this, if we're going to go take care of it surgically, open anterior approach, midline incision, transverse belly incision, we're doing much less of the time now. It's a much more invasive procedure. You have other organs and things that are right in your way. You've got your colon that's right there. We've got to manipulate the colon. The blood supply of the colon's right next to the pancreas. We have to sometimes manipulate that. We've got a potential to injure that. Now you're injuring the colon. Now you're giving colostomies. You're leaving usually the belly open for several days and coming back several times to bleed. You're increasing chances of fistula. So the open anterior approach is most likely the least desirable way to approach the pancreas nowadays. Minimally invasive is probably the way to go. VARDS, video-assisted retroperitoneal dissection, I'll show you that in a second. Laparoscopic, But a little more uncommon. We're probably moving toward the robotic range now since we do so much more robotic surgery. And endoscopic is probably our biggest one. The GI folks have really taken over the endoscopic, and they have some neat tools to take care of these patients. VARD's step-up approach is a nice article for the step-up approach for pancreatic debridement that was in New England Journal of Medicine a decade ago. But it goes through a step-up approach where you put a drain into the pancreatic fluid collection that's now infected, and then you upsize that drain, and that gets the patient over the hump and gets them better because you're starting to control the infection that's going on. You got source control, you do antibiotics, and then after that, you go in surgically through incision on the side of them without going through the middle, and you pull out that dead pancreas. And this is just a little schematic that's showing that. So instead of going through the anterior abdomen and moving the stomach over and pulling the colon down, actually we go retroperitoneal here. Usually we put a drain in first, get everything to kind of calm down, let the drain a majority of the fluid. It's not going to take out all that dead pancreatic tissue, get things to calm down. And then we take them, we put them in a lateral position, we make a little cut. This is actually like a little 5 centimeter cut here. We follow the drain down, goes right into the pancreatic cavity. We use our laparoscopic instruments like we do for a lap chole or a lap appy. Put the camera in there, goes right down the tunnel. We grab onto the dead pancreas and just pull it out. Little easier as I described it than actually done. You got to be careful. There's some vessels in there and you can get some pretty significant bleeding if you're not careful. And once again, you need the pancreas to be dead because dead pancreas just comes out like a big wet sock, like a dead rat that's sitting back there. It just kind of pulls out on its own. You start yanking on healthy pancreatic tissue, that bleeds, and that can become a major problem. But usually it's not that hard of a procedure. We do it fairly frequently, or not as much as anymore because of the endoscopic, but we do this much more frequently than we do an anterior approach through the abdomen. So the VARDS has made a big jump in how we treat these pancreatic fluid collections without boogering with the rest of the bowels. Endoscopy, like I said, has become a big mainstay in treating these patients, especially when they have a nice walled off necrosis. This is their Axial Stent. You guys all heard about their Axial Stent, right? You know the Axial Stent here. It's a brand name for this stent. It's a lumen opposing stent that goes in here. It's got two, looks just like this. They go in the stomach, use their endoscopic ultrasound, find the fluid collection, make a hole in there, stick the stent through there that keeps an opening from the stomach into the fluid collection. And either they can do that and get the patient over the hump and they let all the fluid drain and the pancreatic juice drain, and they can actually go back and start debriding. This is the picture of them debriding. They've got a little pigtail stent in there also, but this is their grasper that they have. They're grabbing a piece of pancreas, dead pancreas, and pulling out. That's exactly what it looks like. Now, the only thing is between them doing it and us doing it, they go in there and spend several hours at a time, go back in there multiple times over usually several weeks. And this little piece of pancreatic tissue that they're pulling out, it's probably a good centimeter, maybe if that. And they keep going in there and plucking it out and pulling it all the way out and putting it back down and plucking it out. It's a bit cumbersome, but it's good on the patients, okay? When we go and do it with VARDS and pull out the pancreas, usually we pull out the pancreas in one big chunk or several large chunks. It's less time consuming, but it's different methods to do it in different ways that we can. And like I said, they've taken over a majority of this because this is a nice little stent that they have. You can see here in this picture that the stent sitting between what used to be a fluid collection and the stomach here. This is a better picture. I like this one. There's a pancreatic fluid collection. Here's the stomach. They got a stent going through the stomach to help keep it open. So with this technology, they become much more facile at doing the pancreatic debridements. Just takes a significantly longer time to do that. So now what are we doing? I'm still confused about what to do. Well, you can pick an algorithm of what to do. Everyone's got some algorithm of if it's infected, go here. If it's not infected, go there. Symptoms, go here, go there. But basically, what's it coming down to? Leave the pancreas alone as long as possible. Okay, time is everything. Even those acute patients that are infected early, usually you can leave them alone. Antibiotics, put some IR drains in there potentially. Leave them alone. Let everything calm down. Get somewhat of source control. Then go after that necrosis later. If you suspect infection and pancreatic collection, can treat with antibiotics and see or try to diagnose. Like I said, FNAs, you're really not doing FNAs anymore. It's really fallen out of favor. Putting IR drains in, we do frequently. If you do ask for an IR drain into the pancreas, hopefully we can all collaborate on that because we like them to put it below the ribs, not through the ribs, because we don't like to infect the lung or the pleural space. Keep it out of there. And plus, if we have to do a VARDS, then we follow that drain right in. Instead of going in between the ribs, we follow the drain right below the ribs into the pancreatic collection. If you've got a confirmed collection, culture, air on CAT scan, the antibiotics and source control, once again, that's drain, open surgery, uncommon, more likely VARDS or endoscopic. And the big push I have here is for multidisciplinary approach. We really want to talk with these, with whoever's taking care of them, plus the GI folks, plus the surgery folks, to see what's going to be the best approaches for these. Long term, about 20 to 30% of patients will develop exocrine and endocrine dysfunction. You just have to keep that in mind long term down the road, insulin and creon. Also, what if the patient has the walled-off pancreatic necrosis or acute necrotic collection and not infected, but not getting better? That's, like I said, that's where you need to have the discussions. Is it time to go in there and do something? Is that going to be surgically? Do I need to go pull out all that dead pancreas? Is it endoscopically? We need to do an Axial Stent, drain some of the fluid, give them some more time, pick at that necrotic tissue just because they're not getting better. They can't get over that hump because of the necrosis. So that's a discussion that you have to have. Remember, there's always a multiple complications. Please join us up in the SICU, and we can do daily rounds on the multiple complications from severe acute pancreatitis. Pancreatic fistulas, those are one of the more dreaded ones, but if you can get the patient through, it's just usually a long-term drain that's in them. I leave them in up to a year. And then if you have to, then you go back and actually take out part of the pancreas. Disconnected duct, that's the same thing. Middle part of your pancreas is actually dead, and that pancreatic duct's just kind of flopping in the middle of there, just draining fluid. We'll see about what to do about that. Enteric fistulas, that's the big dreaded one. Hemorrhage, that can happen at any time. Abdominal compartment syndrome, usually that's early on. And a comment about this, you're giving aggressive fluid resuscitation, and they can get abdominal compartment syndrome. The estimates are at least 50% mortality. Mortality is probably upwards, and some of the other estimates upwards of 80% if you have abdominal compartment syndrome and acute pancreatitis. It's just not good to have the two together. We will reluctantly take the patient operating room to open their belly, because you have to remember what we're doing is we're now opening the belly, and we usually don't go through anterior to get to the pancreas anymore. We do VARDS, but we are burning a bridge because we will open the belly, they get over their abdominal compartment, we eventually get them closed. We can't go back in that belly for another 6, 8, 10 weeks because everything's frozen there. That means if anything goes on in there, dead bowel, fistulas, you have to go through that way because your VARDS isn't going to work to get your pancreas. We're unable to do that. So it burns a big bridge. And plus, we don't get into the pancreas at that time because the pancreas isn't ready to come out early on, but you have your abdominal compartment. So that's a problem if they develop that. Pancreatic fistula, varying definitions, usually resolve in 6 months. I say usually resolve in a year with a lot of hope and treatment. May have a pseudocyst. Maybe that's where your pancreatic fistula, it's just fistulized to a cyst. Endoscopic therapy may help. We often have GI guys put a stent into the pancreatic duct. Maybe there's some narrowing, or put it in there to try to preferentially divert flow where it should be going to get the end of it to heal. And may require distal pancreatectomy. This is disconnected duct. So remember, the end of your pancreas dies and you got your pancreatic duct and it doesn't scar over and it's just leaking fluid. Either it's going to go leak out or it's going to go through the duct and go to your bowels where it's supposed to go. When it leaks out, it's disconnected duct syndrome. It just keeps leaking fluid. Often these patients have a drain coming out the side. And doing a distal pancreatectomy after pancreatitis is an absolute miserable procedure for us. So we try not to get to there. Octreotide, NPO sometimes, pancreatic stents, but this is a problem, but thankfully it is uncommon. Hemorrhage, CTAs are what we're doing with hemorrhage, and then off to angioembolization. It's very uncommon to go do surgery on these unless you were just there doing surgery. You can pack it, because this is usually what the pancreatic cavity looks like. You can see it here on the lower right. I don't know what anything is in this picture. I've got no idea. I've got no idea where vessels are or what's bleeding or not bleeding, and that's what it looks like in the operating room. So putting stitches in, no idea. You shove a bunch of laparotomy sponges and still take them to the angio. So really angio is where the places that they're going to need to be, because they can get to the pseudoaneurysms in pancreatitis. Colonic enteric fistula. A lot of times we used to go operate on these, not as much anymore, control them with some drains. Then actually endoscopically, they'll go in and put little bear claws on the holes sometimes and try to get this to calm down. More uncommon that we actually go and just do a resection on this. What would happen more commonly than taking care of a colonic enteric fistula is if they just kill off their bowels. So they can get dead colon, because remember your colonic mesentery sits right there at your pancreas. As you necrose your pancreas, you take out the mesentery there, then you've got dead colon. That will go and take out because you can't survive a dead colon. But the fistulas, we just do source control with drains and let this just drain for a very long time. These often heal on their own, or endoscopically, they get bare clawed and closed. Vein thrombosis, very common, especially a splenic vein. There's always a debate. Do you treat splenic vein thrombosis of pancreatitis? Do you not? I always say if it's going to propagate, or I'm worried about propagating, or it has propagated, then you most certainly should treat it, especially when it's getting to your SMV, into your portal system. But it's not uncommon to have your splenic vein get thrombosed, that's sitting underneath all this goo. So what did we maybe learn here? Aggressive fluid therapy early on. Yeah, probably still doing that. No prophylactic antibiotics, so we don't just give them. Feed early as much as we can. Enterally is the best place. Gastric is fine. Nasojejunal is fine. Jejunal, some way to feed them, preferably enterally. Probably minimal role for emergency surgery. Take them right off the operating room. I mean, abdominal compartment, yes. Dead bowel, yes. Besides that, we're probably not doing emergency surgery on acute pancreatitis anymore at all, nor should we be. Most interventions should be minimally invasive. That's the VARDs, that's the endoscopic treatments, IR drainages. Multidisciplinary approach is very, very important. Get everyone on the same page, get all your consultants together, because sometimes do a little bit of this, a little bit of that. This person does something, that person does something. Get everyone together on these. And then I tell every patient and their family that this is like a roller coaster and there's ups and downs. You're going to get better than worse and better than worse and better than worse. You're going to take 2 steps forward, 1 step back. The next day it's 2 steps back, 1 step forward. And they have to be prepared for that, because families really don't understand the pancreatitis. They think just go cut it out and you're all done with it. But they really have to understand this can be weeks, months, and upwards half a year of a roller coaster. So good description to the family for that. That's just a nasty pancreas, so is that, and then put into lecture. Okay, what questions you guys have? I just want to show one video of the VARDs if I have just 1 minute. Not my VARDs, someone else's VARDs, I lost all my videos, but what questions you guys have? Nothing? Did you guys ever see pancreatitis?
If you got a patient that's like hemodynamically stable and making urine in the early stages of pancreatitis, like not elevated lactated, you still aggressively get fluids into the pancreas.
Yep. Because once again, you don't have to have those elevated pancreas. It's much more uncommon that you don't see them, but there are times you won't see the elevation of pancreatic enzymes. You get your imaging study and they got the pain, and that's what it is, and be pretty aggressive with it, because you don't want them to be the one that slips into the moderate and then severe, pancreatitis. Those are the ones I absolutely dread. Can I just show you guys this real quick? I just think it's neat doing VARDs. I don't know if you guys have ever seen a VARDs before, and this is once again someone else's VARDs, not my VARDs. Let's get to the good stuff. So they're placing the drain because they're going to follow the drain. They put it between the ribs. I hate when they put it between the ribs. Just it's a more difficult dissection. I always worry about getting into the pleural space with some type of infection, and then you've got empyemas and VATs and everything else that you're dealing with, as you guys well know. So this is kind of neat. It's already this is what often happens. It kind of points towards your left side usually, because that's where everything tracks. You can see the drain sitting there, makes an incision. It's not that big of an incision. You can see how big his finger is. They're just dissecting down, following the drain down is all he's doing, sticking your finger there. And usually this is what happens. You just get your finger in there and you get the goosh, right? And sometimes you weren't even getting that out your drain, and then that comes out. You're like, my God, no wonder they've been sick for the past, 2 months. And this is just a picture. And see what I'm saying? This is all just goo, right? And what is what? I have no idea what's what. Colon should be up here someplace. Kidney should be down here someplace. Spleen's up there someplace. We're not intra-abdominally, retroperitoneally. So, and it's a nice view, but so they put a little port in here so they can see. Remember, this is just a small incision on the side, usually left lateral, and they're grabbing a little grasper. This is the part that you got to see here. This is what usually happens. See him pulling this thing out? He's pulling some of this junk out. Let's see. And he's pulling at what's dead, because if you pull at what's alive, you're going to start causing bleeding. Done that before. Now look at this. And this is what he pulls out. I said a wet sock or a dead rat. Or GI can go nip at that for the next couple months with their little things. And they do a great job, but this is why it takes so long, because they're sitting there nipping at these little pieces for that big chunk that you just pulled out the side there. And that's often how it comes out. You got this giant cavity where, of course, the pancreas used to sit at, where it doesn't sit anymore. Put a couple drains in, maybe bring them back one more time and wash them out. But that's the way to go, is these minimally invasive approaches. Like washing with antibiotics? No, the only people that do that are plastic surgeons and orthopedic doctors. So yeah, antibiotic solutions have no data to say that they do anything. Because number one, you don't give enough dwell time for them to actually do anything. You have to use a cytal antibiotic as it is, so it kills something, but it doesn't do anything. We just put a couple drains in there, close part of the skin, and you're done. And pray that they don't erode into some vessel that's sitting in there. What else? Good. We all know about pancreatitis. Excellent. Okay. Thanks for having me, guys. Do you want me to pause recording or just keep going here?
Yeah.
Where was it? You do it. You do it. Anyways, thank you very much. Just pop my thing off there. Yeah.